right, well, I think I'll just transition and I'll talk a little bit. We've had a conversation about stigma related to sexual minority populations, and I'll talk a little bit about stigma and vulnerability amongst Black women living with HIV. All right, well, I think I'll just transition and I'll talk a little bit. We've had a conversation about stigma related to sexual minority populations, and I'll talk a little bit about stigma and vulnerability amongst Black women living with HIV. So just a little about my academic lens and how I really come to my interest in ethics, especially applied ethics. My PhD training is in public health. I completed a postdoc at MD Anderson Cancer Center where I focused on behavioral science and intervention development. My lens is community engaged. I haven't always done CBPR work, but that's the direction that I'm currently moving in with my career. And also my training in ethics consists of, I started an undergraduate at Tuskegee University in the National Center for Bioethics Research and Healthcare. I got an MA in Bioethics and Humanities from Michigan State in Fordham. So, I say that my actual integration of public health and ethics is due to this institute. So it's really an honor to be here today. Before, I feel like I did public health work, I tried to do ethics work, but this really is the culmination of my work in ethics, applied ethics. So I know I'm preaching to the choir here, so I won't go over all of this, but we know that HIV/AIDS remains a major health issue for African Americans in particular. Right now, there's a lot of work that's happening with integrating HIV surveillance and prevention, in addition to PrEP, pre-exposure prophylaxis. And again, I'm focusing on Black women living with HIV. There's also evidence that suggests that Black women underutilize PrEP because of lack of awareness and lack of access to PrEP. And we know right now, 90-90-90, the goal is to increase access to care and improve health outcomes for all individuals living with HIV. So this is something that I want to highlight. In working with Black heterosexual women, there are instances where individuals say that, oh, African American women or Black women are not really a high-risk population for HIV. This comes up a lot when you think about this population that is not necessarily getting infected due to drug use. So, I think we have to really think about this from a health equity approach. You can see the numbers: 4,000 Black women were infected with HIV in 2017 compared to 1,000 Hispanic women and not 1,000 white women. So there are definitely some huge issues as it relates to this population and some major health inequities. We know that there are multiple factors that increase susceptibility or vulnerability to HIV amongst African American women, in particular socioeconomic status, economic disadvantage related to not being able to access healthcare and HIV preventive services. Again, PrEP is something that has come up more frequently with African American women underutilizing PrEP. Scholars are arguing, again, more recent work, that the high rates of incarceration amongst African American men, for instance, can serve to disrupt these social and sexual networks with African American women and increase risk there. So when we think about addressing HIV from a more structural perspective, we have to think about Black male incarceration. We also have to think about over-policing and how these factors can potentially lead and elevate risk amongst African American women. So I'll highlight two areas today, since we're talking about intersectional vulnerability and marginalization, as well as HIV/AIDS-related stigma, and how that might intersect to increase HIV vulnerability or risk amongst Black women. So I looked at this figure from avert.org, and when we think about compound marginalization, you can see that there are multiple aspects of stigma: HIV/AIDS-related stigma, sex work, sexuality, drug use, gender. So these are some examples of stigmas that can intersect, and this leads to marginalization, and some forms of marginalization include discrimination, violence, harassment, and abuse. And all of these intersect, and it can lead to poverty and ultimately sickness. So this is just one way to think about how these stigmas intersect and are compounded to increase HIV, not only HIV risk, but the experiences of HIV, healthcare engagement, or other types of engagement as an individual living with HIV. So again, highlighting intersectionality, I frequently refer to the work by Kimberly Crenshaw. She talks about intersectionality being a lens through which you can see where power comes and collides, where it interlocks and intersects. One of her recent TED Talks, she talked about intersectionality as being multiple levels of social injustice, or injustice square. And I think that's especially important when you're thinking about the populations that we're working with and the overlapping marginalization that they experience. Recently, a colleague did some work and published a qualitative article on intersectionality, and I actually have this as a reference. And she highlights that intersectionality offers a constructive lens through which to contextualize the health inequities faced by women living with HIV, and this population was primarily African American women. Lisa Bowleg is another scholar doing a lot of important work with intersectionality, and she highlights it as a concept that seeks to characterize the convergence of multiple stigmatized identities within a person or group and to address their effects. And more recently, serving on an NIH panel with Floyd, who was amazing and who is great at navigating and summarizing grant critiques. I have a lot to learn. But some of the things that were highlighted in that grant review included stigma as one or more coexisting health conditions such as HIV, socio-demographic characteristics such as racial, ethnic, gender, sexual orientation, and immigration status, and finally, behaviors and experiences such as substance use and sex work. So this is just a brief snapshot of how I contextualize and the things that I draw from related to intersectionality in Black women with HIV. So I'm just going to go back to some earlier work that I did because it really, again, has encouraged or really inspired my current work in research ethics. And before coming to the Institute, I did a lot of qualitative work, and the reason I was interested is because I had these ethical challenges in the field, and was like, hey, there's something that's happening, and I don't really have the literature or the expertise to really address some of these issues or even understand what's happening in these interactions between me and my participants. So I'll talk about an earlier study with 42 African American women in rural South Carolina. I focused on public or HIV AIDS related stigma, so we all know that stigma is a huge issue, the short of it. And I focused on African American women, and I recruited these women from clinics and AIDS service organizations, and I'll talk about later how that was somewhat problematic. I did qualitative analyses. At the time, we used in vivo software, and I know Alexis is going to talk later about the types of analyses and how to formulate an interview guide. But here, I definitely want to highlight the areas where I interviewed. So there were 5 counties in South Carolina, and these 2 areas are part of South Carolina's Low Country. So, it was there that I experienced some issues, and I felt as a researcher that I was entering an area that was highly stigmatized with populations. And again, I'll talk a little bit about that experience in these areas. So some of the interview questions included, how did you find out that you were HIV positive? Who have you shared your HIV status with? And again, not directly asking about stigma. Again, I can also share a more recent stigma guide that I used with colleagues. Again, this was earlier in my career, and there were some things that I definitely would have maybe asked differently. Please describe the things that you do to cope with being HIV positive. Please describe your experiences with the healthcare system. And then we talked about both positive and negative experiences. And I was also interested, because it was a population of African American women, about advice that women receive from healthcare providers related to becoming pregnant or not. So there were some interesting findings related to that, and I published that in a different paper. So some of my interview challenges included, within a 90-minute interview, obviously there are issues with building rapport. So my earlier interview questions included, tell me about your day. What do you do when you wake up? How does your day progress? And some of those questions were really important because I learned a lot about people. They would wake up, they would pray, they would take their medication. Some individuals talked about feeling really sick in the morning and needing more time to get dressed because of the side effects of medication. Some of the questions, of course, the questions that I posed were really sensitive, and a lot of women talked about childhood trauma, sexual violence, rejection and stigma from family members even, and just all aspects related to acquiring HIV. So sometimes these interviews, women obviously became very emotional. So that was something that I had to do in terms of adjusting and maybe stopping or going back to certain questions or not asking certain questions given the interaction that I had with participants. So I mentioned that I had an interest in stigma, but the overarching project was about pregnancy intentions with HIV positive women. And a lot of women, you know, we would talk about pregnancy and they're like, okay, well, yeah, it's just another part of life, and let's talk about all these other things that I experienced. So my lens was very much reproductive health. Like, there's so many things that we can talk about related to this, and they just wanted to talk about their general life experiences. So again, there was some flexibility there, and I allowed women to talk about the things that were essentially important to them, which I'm sure my dissertation advisor did not appreciate. Discussion of stigma. So we talked about stigma, but some of the interviews took place within a conference room in a healthcare setting, and I realized later that many women were saying, well, I experienced stigma here within this clinic. And then that's when I thought about, you know, I might want to change the location of some of these interviews. And finally, from a researcher perspective, I felt like I walked away with the weight of all of these stories, some of these stories of resilience, but then some of these stories of pain dealing with the population, and I had to figure out how to navigate and cope with that. So a little bit about my population. Less than $10,000, predominantly 73% of the population earned a salary of less than $10,000 yearly, primarily unemployed, single, reported acquiring HIV through sexual intercourse with males. And again, I mentioned that most of these individuals were seeking HIV/AIDS healthcare. So not necessarily generalizable to people who were not engaged in care, but still very aligned with other work. So just for today, I highlighted some of the major themes. Again, I don't view the study as being an intersectional study, but I definitely looked at stigma on multiple levels, the individual level, interpersonal, as well as the institutional level, consistent with the socio-ecological model. And some of the things that I found related to the interpersonal level, for instance, was a lot of stigma that women experience. They talked about this one quote: my mom found out I was HIV, you know, she didn't want me to be around my kids. She didn't want my kids to sleep with me. It hurt because, my kids can't catch it. You know what I'm saying by touching or kissing them. So this person was relatively young and talked a lot about dealing with stigma within her direct family. There are other individuals who talk about living in certain types of housing that people recognize as HIV-related housing. Those are things that I think people don't think about when they design services for HIV-positive individuals, in terms of where these services are located, whether or not they're recognizable to other individuals. Even with clinics, are we concealing HIV care within larger structures so that individuals don't have to anticipate stigma along the way? So this one person said, I'm more depressed than anything. I don't look towards tomorrow. A few people come around and it's like a clique, and where I live in housing, most of the people have HIV. And people in the area, they know about that housing situation, so they automatically start talking. My family has pretty much disowned me. As it relates to the institutional level, and during the time I was very surprised that this was still happening, but these data, I recently did a similar study with colleagues at University of Alabama at Birmingham. We're finding similar things about pharmacies and healthcare providers. This person said, I would take my prescriptions to the pharmacy 2 towns over because I didn't want to run into anybody or have anybody in the pharmacy filling my HIV medications in my hometown. It's a small town. So again, thinking about pharmacy provisions and how we train pharmacists and people who work within pharmacies to make sure that they're not disclosing status or sharing people's status based on their medication or calling out their medication. Hey, your Truvada is ready. That's something that someone just mentioned in another focus group. So definitely room for educational intervention. And as it relates to intersecting stigma, this one participant said, it's so hard on women today who are HIV positive because there are so many things that we have to deal with that the opposite sex does not have to deal with. As a woman living with HIV today, as a Black woman living in this world today, I feel like I have to continue to stand. So again, there was a lot of discussion related to resilience and how women felt like they were able to overcome adversity through support groups, through praying, and through other supportive environments. So just to highlight a brief overview, many women describe stigma at multiple levels. The stigma made women more vulnerable to discrimination, and many disclosure made women more vulnerable to stigma and discrimination. So in my earlier questions, when I asked who have you disclosed your status to, some people said that they hadn't, but others who had, mentioned that when they did, this is what happened and this is how their lives were affected. Some people said they lost their jobs. Some people were disowned by their families. Some people were shamed within church communities. And, in this paper, I really talked about how the lack of safe spaces for HIV positive women is an issue. So while, some people may have churches who are uninfected, some HIV positive people at every intersection experience stigma and discrimination, and this has negative health and social consequences. But the aspect that just really made me interested in pursuing this research ethics work or applied ethics work is, in my experience as an investigator, I felt like HIV/AIDS just really invaded the entire research process. So then I learned, I'm like, okay, so something is happening here, and I attended the institute, and I realized that there's a growing body that highlights evidence-based research ethics. So you're here, you're in the right place to do this work. And again, this paper just talked about how marginalization can sharpen ethical tensions and permeate and complicate the HIV/AIDS research process. Not only can it present challenges for research participants, but also research staff who are engaged in this work in these communities and spaces that are marginalized. And Dr. Fisher's work from 2014 highlights that acknowledging these vulnerabilities experienced by individuals in communities who face multiple stigmas is really critical to informing the research process, and more importantly, tailoring participant protections to a particular socio-cultural context. So as a person in this institute, you have the opportunity to really influence that in an innovative way.
You know what I'm wondering, Faith? You've said so many things here. I'm wondering, before we go to the next study, maybe we can go back to a couple of things.
Sure.
And have people talk about it. There's a number of things. The first, I don't know where to begin. I mean, you have that picture that you have. I think there's three things. There was the compound marginalization, in which you included stigma, right? That's slide 7. Then there was the multiple definitions of intersectionality on slide 8, which I thought was very interesting. And then there was the way that you put together your themes in that last slide. And
okay.
It's not easy to, the slide's not necessarily easy to see, but what I thought was very interesting and might be helpful is if you just went over a little slower.
Oh, sorry.
But just how you have 4 different themes.
Right.
And they're really very interesting because one is at the interpersonal level, right? Stigma and discrimination at the interpersonal level. You then have at the community level, and you define that. And then you have institutional level.
Right.
And then you have at the intersectionality. And I think maybe you could a little more slowly define those, and maybe everybody then can be thinking about what that means in terms of how the themes that you're going to be thinking about, because I think this was a very clever way that you define a theme and then you give an example, but the way you define the themes, I think, is very helpful.
So of course, after
based on theory.
Oh, yay! So of course, after starting the initial analyses, so I talked about using deductive codes. So those codes were based on the literature. Those codes were based on our research questions and what we thought we should find. These were essentially inductive codes, because as I started going through the literature, I learned a lot about stigma, and I was like, oh, there's something happening with stigma, but even more importantly, it's happening at these different levels. And that was something during the time, again, understanding the socio-ecological model and the intersection of all these levels. I was like, oh, so maybe we should think about applying SEM to conceptualize this work. And again, we had to define it because there are different ways that people define interpersonal versus community. So yes, we define like interpersonal as the immediate social environment. So again, people's interactions directly with their family. I think we also included churches at this interpersonal level, and then community level, housing. But again, some of the stuff is very much, it's fluid. Some people might define, let's say, housing on the institutional level. Oops. So again, it's all in how you operationalize your terms. We had a research group, and this is sort of what we decided to do. And at the institutional level, almost everything within institution related to pharmacies and healthcare settings, there were some women who were also formerly incarcerated, and they talked about that going into prisons and doing HIV prevention and encountering a lot of stigma because people knew they were HIV positive. So that was another factor. And then finally, after doing a little bit work, I realized I was like, there might be some quotes. There was a lot of discussion about women really taking pride in being African American, but also highlighting that it's challenging living as a Black woman living with HIV in this day and time. So that's essentially how we developed those codes. So these were actually codes that we included as part of our code book.
What I think is very interesting, people might want to think about is, your first theme, you were very specific. It was direct interpersonal interactions as they relate to stigma and marginalization. Mm-hmm. The second one was these experiences within the somewhat broader community.
Right.
The third was what would happen in terms of these larger social structures, like hospitals, right, schools, mm-hmm, whatever, mm-hmm, right? And then the fourth you defined in terms of co-occurring, overlapping. I mean, this is language I think is very helpful for other people as they're beginning to think about themes, because it's using qualitative study in almost an operational way in terms of where is that level of interaction or experience taking place, and it was overlapping stigmas required on various sources or multiple levels. So, whether or not within your MRP you're talking about stigma or not, maybe we could just very quickly begin to just think about what levels are you talking about in terms of the kinds of questions you're asking, right? We've got interpersonal, community, institutional, and then intersectional, right? Multiple.
Right, and there are some people, you could add another level, the intrapersonal, the individual level. So when people think about internalizing stigma, yes, I didn't include anything from that, but remember when I drafted my interview guide, I wasn't thinking social ecological models. So again, this was more of an inductive understanding of what was happening. But now, of course, if I developed a study, I would definitely have these levels, and I would organize my interview guide just based on some of these findings, recognizing that this is commonly experienced by HIV positive people.
I think I wanted to say the other thing that I think can also happen in qualitative work, or at least what's happened to us recently, is I like to use behavioral theory to help me think through mm-hmm, the kinds of questions that I might ask.
Right.
And I think as it relates to the MRP, like you could think about like risks and benefits as outlined by the Belmont report. You could think about the principles of justice that we know about. Those can be really useful, but then it can be the case too that even though you interview based on a particular theory, that what ends up coming back from people is something entirely different. Right. So we recently built a whole study around the behavioral model for vulnerable populations, and then as it related to understanding HIV uptake, it was really about health beliefs. And so we had to reframe what we were doing.
Health belief model. Yeah.
So I think just having theory, whatever your working theory is that relates to the work that you're doing in your field, can be really useful as a way to set up your qualitative guide.
I agree. And I can provide that. There's a theory at a glance little book. It's a PDF of all the theories that we use in health behavior. So yeah, I can share that. No, it's like the go-to guide, because that book is the purple one. Yeah, the purple one. Yeah, really dense. Really dense.
No, I just want to add on that I really think it's great that you're providing a great example of how it's an iterative process. Like you had your set theory ahead of time, and then of course the data led you to something else, and other theories led you to something else.
Right.
It's not, you're not gonna just be finished initially, you really have to kind of keep digging through the data.
Right.
And being flexible and open-minded about what you find.
Exactly. So, sorry.
Maybe we could also go back to
Sure.
your there were multiple definitions. It just, there was so much.
And I can share this. No, I'm going to
Yeah.
share this. Yeah.
Good stuff. I don't want to eliminate it. So on slide 8, if you could show that.
Okay, what's slide 8? Okay, there it is.
Intersectionality.
Okay. Got it.
That one.
I thought that was really interesting. Once again, I don't know if everybody can see it, but there were multiple definitions here that were really very distinct.
Yeah, there's a million, and these are the ones that resonate most with me. And as I said, Lloyd probably knows all this literature even better as the review expert on intersectionality. But I think just thinking about the earlier literature with feminist scholars, Black feminist scholars, and that is more recently starting to get applied to the HIV work, and we've been talking about intersectionality, and now folks are like, oh, intersectional stigma, like this is new, this is what's kind of trending, whatever that may be. So really trying to separate these aspects, and when you think about developing studies and measurement, some colleagues include different types of scales within a quantitative survey. So they might have a scale on poverty stigma, a scale on substance abuse stigma, a scale on HIV stigma, a scale on gender stigma. There are, I'm sure, other ways to do that, but again, we're still learning ways to really understand and measure, and maybe there's better ways that we're hoping to find out in the future how to do this work.
Let me just interject again, okay?
Sorry.
What I think is really interesting, and I want people to be thinking about, is the first one is about power. I mean, and they're very interestingly different, okay? And I'm so glad that you provided this, because the first one is...
You told me to.
It
was a great idea.
You totally told me to.
So people can own whatever they want. Okay, so the first one is a lens through which you can see where power comes and collides. I mean, I think that's fantastic, and that may be something important to your MRPs. It depends. The next one is really focused on social injustice. And injustice squared, which I love that. That seems to be a great phrase. But that's social injustice, which is somewhat different from obviously everything's related. But is social justice these kind of intersectioning social justices mixed in? The other one. Let's see. That I thought, and maybe other. Oh, so then the other one is about identities. So identities is very different than power from injustice, and so I think we want to kind of recognize, and then the fourth one, whatever which one is, coexisting health conditions. So just like what you did with your themes, which I thought was really good, is now we've got. Even talking about intersectionality, the use of these terms, power, injustice, identity, co-health conditions, these are 4 very different things that can help guide our questions or our themes. So I just want everybody to be keeping this in mind as you move ahead in your thinking and we open this up to more discussions,
But the important thing you're saying, Celia, is that it's about the way you think about it. It's intersectionality. I mean, I'm absolutely no expert, but it's not rocket science. It's that there's more than one thing. All it is that there's more than one thing that coexists.
Right.
But what intersectionality has done is it has stopped people from easily saying, oh, just get over it. Oh, you don't like the way the doctor treats you. Just suck it up and go to the doctor because that's all you need, because it's bombarding you in every area of your life. And so it stops that this is not a big deal kind of invalidation of what someone might describe as one narrow piece of stigma. And in turn then lets you look at these other theories because it's broad. It's across individual, interpersonal, community, like it's everywhere. So it's, intersectionality is just a word that says two things co-occur. It's just a longer word so you sound smarter. It's that people experience multiple types of stigma simultaneously. So then when you look at it that way, it's not an easy, there's one type of stigma, just fire the doctor and it gets better. Because you can fire every doctor and there's 1,000 other types of stigma. So these things about identity and justice, that's really the theme. Like that's what it's opened up, is that language that nobody would have applied to one individual 5-item stigma scale. So those themes that are here and the themes you have at the multiple levels, that's where you can really get some traction on this, as opposed to just these very narrow, concrete, ultimately ineffective interventions. And that's what's really great, is organizing it that way.
I agree.
And I think taking it away simply from identity, that intersectionality is just not who you
Right.
think you are. Because,
Right.
you know, most of us aren't thinking about who we are as we're experiencing discrimination or
Right.
not.
Right.
You know, we're not thinking about that. We may reflect on it later on, or we may be
Right.
fearful of it walking because we're afraid of it. But, you know, it's just like when I was talking about the goodness of fit and how it takes the burden of vulnerability from the individual and places it on the research context. How do we reduce research vulnerability? I think this is saying the same thing. It's taking intersectionality out of a burden on the person in terms of who do I think I am at any one moment, as to what's the power that's going on, you know, within a system or persons that we're interacting with. You know, what is the social injustices that are going on, you know, that I may not have control over, irrespective of who I think I am.
Right.
You know, so I think, you know, for us to all be thinking about that in how we want to frame things, and not just thinking there's a collapsed version.
Right. Yeah, and some of Crenshaw's earlier work, she, you know, part of the impetus for this is that she's like, there's civil rights and there's feminist movements, but somehow Black women are just left out of the conversation with discrimination. And, you know, more recently, she brings up this in terms of, we know a lot about transgender men, but there's so many transgender women who've been killed lately, and people don't know their names. We know about Black men and Black women who've been killed, but you know, these populations, sometimes women are not included in the conversation because of all these intersections. So it's just interesting how sometimes multiple intersections and multiple marginalization can make someone invisible to society. Oops, sorry. I'm so sorry.
Did too good a job, Faith. And but go to
The compound
Go back one.
marginalization
your picture
diagram.
one. Your
Okay, so
diagram.
yeah, I actually,
There it goes. Okay, so I think this raises this once again is a really interesting slide. I think it raises issues regarding what is the difference between stigma and marginalization.
yeah.
And it challenges us. I don't know if, you know, there may or may not be a difference, but it challenges us to. So you separated, or somebody, whoever
So
you're
stigma
citing
leads
there.
to.
What did you feel?
Yeah.
What did you feel the distinction was in this diagram between stigma and marginalization, or whatever the person?
Me?
Yeah, whoever it was.
Oh yeah. So yeah, this isn't a UNDP, but it's stigma can lead. These stigmas can lead to marginalization, socioeconomic and legal marginalization. So I know sometimes stigma and marginalization is used interchangeably, but I think, you know, the stigma, what they're saying is the stigma happens first here, and then the marginalization is what leads to these other aspects and ultimately adverse health outcomes. So there's different ways to think about it. So, you know, there's a discrimination in terms is more of the act. Sometimes people think about, so what's actually happening, you're discriminated against, but initially, again, there's the stigma that and other people might think about it differently, so I would even be interested in how you conceptualize stigma and discrimination and marginalization. Uh-huh.
So I know that it's really one of those things that the fields are really grappling with, right, in terms of like how to define.
Mm-hmm.
And one of the things that I noticed is there was probably a lot more written about it, the marginalization piece in the economic literature, because there's a lot of talk about economic marginalization in terms of joblessness and et cetera.
Right.
And I
makes
think the
sense.
thing has to do with sort of like being sort of separated or in some way kind of locked out of something.
Got it. Yeah.
And the stigma is, I would say, attitudinal that can lead to behavioral.
Right.
That's where I thought that there's sort of the difference in the definitions
Right.
that were a little bit clear came
Yeah.
from. But again, like you said, people tend to use them interchangeably, but I think that is a mistake.
Yes, stigma and discrimination, or stigma and
We probably need
marginalization.
to just do a better job of measuring, which we there
Yeah.
are very few measures out there anyway
Right.
about marginalization anyway.
Right.
Um,
Yeah, those are good points. Yeah.
and then to add to it, one of the things I thought about was that I thought that marginalization could also be a self-concept or something that someone also internalizes, which is the way that I chose to measure it, which is a whole nother thing.
Okay.
But there is a way that you can also internalize marginalization as well, that you're starting to feel the impact of marginalization.
Right. So if we can change stigmatizing attitudes, we might be able to reduce marginalization. Maybe.
I think it's also interesting, I'm just thinking of our horrible immigration problem right now, but that marginalization can produce stigma. So that in some sense,
Right.
you're hearing these poor people,
Oh,
right,
yeah.
who are
Yep.
That's
experiencing
true.
violence in their country, and then they are stigmatized because it looks like they're just trying to get in someplace
Yeah.
illegally, and don't they understand,
Right.
and why don't they have
Yep.
a toothbrush, and, you know, all those kinds of things. So, you know, this bidirectionality
Right.
of marginalization and stigma becomes very interesting and something that we need to think about. And I think it feeds in a little bit to what we were talking about earlier as, you know, in terms of just even defining people as at HIV risk. The extent to which that's their margin, that's the health disparity, which is probably part, but then is that feeding into the stigma? I mean, clearly we know when the HIV crisis first came into play, that really exacerbated sexual orientation stigma. But. Okay, and now back to your ethics of research lessons learned. Sorry. And only I want to bring this up because remember, one of the things that we're asking you for in your, you know, for Monday when you're giving your presentation is what is the impact? You know, what's the potential impact? What, you know, and we're saying that because on grants now you've got to define. Nobody cares about, you know, significance now has become an empirical question, right? I mean, and so now it's impact, and when you're reviewing, it's impact within the next 2 years. So you have to hurry up and show the impact in the next.
So you can only say that it's going to take you 3 months to get
Right.
your study started.
Yeah, and then disseminate.
Well, you
pretty
don't.
quick.
It's not a rule, but don't say 6.
Yeah, and this diagram or whatever it is, word art, is from my field notes. So keep really good field notes. I mean, sometimes they're actually more insightful than the actual data. So these were some of the things that I kind of found, like in my notes. I was like, am I safe? Is the study ethical? You know, I just kind of generated some of this. Are the women safe? Like women saying you can't come into my home, which is what I'll talk about in the next 10 minutes of the presentation, about just my experience again with engagement in the field. So I will continue to talk about the ethics of this.
Well, what I love about the first bullet is this notion that how these exclusion, stigma, discrimination can make individuals feel uncomfortable in places that non-infected or you know, the non-stigmatized person might feel comfortable.
Right.
And I think, you know, that's something to keep in mind. What you know, because a lot of times the populations that we deal with, they're always kind of compared to, you know, a less marginalized or typical or whatever we want to say population. And
Right.
I think, you know, we can succumb to that sometimes as well, because that's how we've been thinking. So I want us all to be thinking about that as well. Okay.
Okay, so the next part, again, this study was essentially inspired by my work here with the Institute, and Dr. Fisher is a part of this recently accepted paper where I talk about ethical challenges related to conducting qualitative research. So I just kind of had the opportunity to put some of these concepts together in a paper based on my experience. Okay, so the next part, again, this study was essentially inspired by my work here with the Institute, and Dr. Fisher is a part of this recently accepted paper where I talk about ethical challenges related to conducting qualitative research. So I just kind of had the opportunity to put some of these concepts together in a paper based on my experience. Some of the considerations that I highlighted related to qualitative research, these are things that we know. Sometimes there's prolonged immersion in other people's lives depending on if people are doing ethnography. We ask very intimate and sensitive questions, especially with working with populations who are stigmatized and marginalized. The design is emergent, so sometimes we have to make a lot of changes. It's important to really think about when you're reporting these data, participant stories, I mean, I have seen stories in the literature in certain places and was like, wait, I saw this in someone else's study. So, just really being careful the way that we're reporting this, removing certain identifiers from our work, things that may not even appear to be identifying to us. That's important as well. But finally, in this study and other studies, I've just realized that you're going to make changes to your protocols and your procedures if you're doing qualitative research based on some things that pretty much emerge in the field. So part of my, for the earlier study that I talked about, I highlighted that I made a change to my protocol because I was having difficulties getting women to stay at the clinic. So I learned from some women that, they felt stigmatized within the clinic. So I don't want to talk about HIV stigma in a clinic that I feel stigmatized. So I changed this to talk about, I said that I would conduct these interviews in a place that was mutually safe and private for both the participant and the researcher. And this is what ended up happening. There were 19 interviews at clinics and AIDS service organizations, 12 interviews in participants' home, 1 in a hospital room, and 8 in my car. So I talked a little bit about how that, oh, that's not actually my car. I couldn't find a picture of my old car. But I actually learned a lot from, the actual interview settings. So in this paper, I talk about the ethical challenges and lessons learned related to conducting qualitative research in different settings and recommendations to improve these practices. So again, just thinking a little bit about the methods, my framework for this was the Belmont report, which I know has some limitations, but just thinking about this from a research ethics perspective. I use those aspects in combination with field notes and observations. Again, I conducted all of these interviews, so I am intimately engaged with those data. And then I, again, use the same iterative process. But what was different about this project is I highlighted, like in going through the data, I'm like, what are the case studies that are most salient to ethical dilemmas in the field based on these interview settings? So this is what I know you can't read this. Don't freak out, Celia. So these are the things, I'll present a summary slide, but, the first study was an interview with a participant, pseudonym Sandy, in our hospital room in the presence of her husband. Again, my goal was to allow participants to select their interview setting so that they felt comfortable. This person said that she was in the hospital, she was admitted, she had a lot of free time on her hands, she was pregnant, and I, was reluctant, but I did meet her there. And when I got there, I was like, she seems fine. She's in really good spirits. Let's do this interview. But then her husband was in the room. And that was something that I really didn't expect because I thought he would leave once the interview began, but he didn't. So she said, hey, anything you have to say in front of me, you can say in front of my husband. And I was really concerned about this, but the husband was like, well, I know my wife's HIV positive, so why is this even an issue? And then I thought about my perceptions, thinking about HIV and framing it as something that was stigmatizing, whereas in their family, it wasn't. So again, deferring to her and thinking about respecting participant autonomy. So this was sort of what that theme was. And again, I'll kind of highlight this in the end. The second interview was with a participant that I call Shelly, who was in my car. My first scheduled home interview. people had transportation barriers, so they're like, sure, come to my home. But when I got to her home, she literally stood at the door. She was like, you can't come in my house. And I'm like, wait, why? I drove all the way here. And she was like, nope, but we can go in your car and do these interviews. So after, talking to her a little bit more in my interview, she was like, well, I haven't disclosed my status in the disclosure question to her housemates or anyone else who she lived with. So that was the issue there. She was very anxious during the interview, and again, I continued the interview because that's what she requested. So I respected her wishes related to that. But it was definitely a different experience. Again, in here I highlight that it was hot, she was smoking, she was anxious, I was anxious, but that's, what it was. So the last interview that I highlight, the third one, is one of the interviews that I conducted in Low Country, South Carolina, and here, one of my classmates at the time was like, I don't think you should travel to the Low Country by yourself. You're not familiar with this area, and he also knew the neighborhood that I was visiting. I was like, I'll be fine, but he decided to come anyway, and he waited outside of the car. So when I entered her apartment, I realized that everything was just kind of in disarray. I couldn't figure out what was going on, but as soon as I walked in, I was greeted by this large, menacing, barking dog, and, there was like a pad right by my leg during the interview, and, all these things were happening, and during the interview, she was served an eviction notice. So that was something that I really struggled with, and, I remember her saying, like, can I just have another day? And the landlord was like, no, and it was just really awkward, and I was kind of packing my things up, and then when she came back, I was like, well, I can just come back, and she's like, no, I need this compensation, let's just finish the interview, I'm fine. Again, thinking about like my ethics training, I'm like, is this coercive now? And then, but, knowing now that it's less about that, and it was more about, respecting what she wanted. Had I left, that would have been like showing her that I was, that the situation was uncomfortable, and I also could have further stigmatized her by leaving her in this state. So I continued her interview. So again, these are all of the just kind of things that I dealt with, the 3 salient cases in the study. But as it relates to, these principles, what we think about in theory is very different from the practice aspect. So here, I think about a person with diminished autonomy, and, participant vulnerability is not very well defined. And it's like, what does it really mean to be vulnerable? Just because you're HIV positive and you're a woman, does that mean you're vulnerable in these settings? And again, my situation with one of the participants was very different than, someone who felt very empowered. Like, I tell everyone I'm HIV positive. Like, my husband knows I'm having a baby. Like, life is great. My life is no different than someone who's uninfected. Definitely a lot of variation there. What I learned is that you have to engage participants in the resolution of ethical dilemmas to really respect and optimize their autonomy and respect them as the experts of their own context, the expert of their own lived experiences. And again, from some of Fisher's work, she highlights that making judgments solely on the basis of ethical expertise and opinions does not acknowledge individuals as moral agents with the right to judge the ethicality of investigative procedures in which they participate. So that really resonates with me and my work, again, centering community perspectives and centering participants. Related to benefices, sometimes we definitely have to, know that we don't always know what's best for participants. And that's something that I'm finding now, and a lot of people are starting to highlight that in more recent work. Corby Smith talks about that we need to let participants and populations assess their perceptions of risk and harms, again, as experts of their lived experiences. And the last aspect is it's important for us to mitigate those barriers. So from a traditional perspective, or researchers, I know, Alexis, you talk a lot about doing field work, and a lot of PIs don't necessarily go in the field, and they don't necessarily know what happens, but it's important for us to have that direct experience and exposure so that we can make those changes to our protocols and procedures. And when we think about populations being economically disadvantaged, we had a conversation about that the other day. So are people who are just poor, are they the only people who are coerced? Like, I participate in anyone has D-Scout? What is that called? It's a research participant app. Like, Facebook sent it to me a while back, and I was like, oh, I'm not going to do this study. And then I saw that I was being compensated $200. I'm like, oh, this is great. I can buy a new pair of shoes or something. But so yes, was I coerced? Yes, probably so. But
It's not coercion.
That's not coercion.
Okay,
Unduly
okay.
influenced.
Okay, unduly
Possibly.
influenced. Okay.
And unduly is judgment. As a
Okay,
judgment.
okay.
But it's
Okay.
but it's not coercion. It's
You
really
rated your
undue
time.
influence.
How much
Right.
is your
So
How
how
much
does
is
it
your
relate
time
to
worth?
populations who are poor? So
It would only be, number one, if they perceive that there's a risk to them of, you'll hear about this with Brandon.
Okay, okay.
If there was a risk to them of participating and they felt they couldn't refuse and had to, and had to have that risk.
but how do we know that participants
Well,
felt?
that's why we do our research.
Okay.
But,
And that's
Okay.
why Brandon does all of
Okay, good. I look forward to his presentation because these are concepts that sometimes I'm like,
it. Yeah.
yeah. So again, I won't go over all of these things because I think it's time for lunch. But two of the things that I think are especially important on here, the slide, the need for practices that help identify investigator bias and positionality. So I think you guys talked a little bit about positionality the other day, and I'm able to, reflect on some of these things that are happening again through my field notes and observations and really thinking about who I am as an African American woman doing this work with African American women who identify as being infected or disclose being infected with HIV. I consider myself to be more of an insider and have also an outsider perspective. The outsider perspective, I have very different upbringings from many of these participants in the study, so I don't make assumptions about, being the researcher who knows everything that happens with HIV positive women just because they're Black. That's not the case at all. And as a person who is an academic, that places me on the outside as well. But my initial visible race and gender sometimes gives me entree into communities, and it's up to me to maintain that rapport. So it's just sometimes it might be the initial, like, okay, you can do this interview, but then I have to make sure that I'm able to sustain that through having, again, being transparent with communities and letting them know, centering their voices and letting them know all the time, you are the expert. This is why I'm here. So you mentioned there are things that you know that I don't know, I haven't experienced. And finally, the last part, I highlight in this paper the moral responsibility of health equity and even ethics researchers. So, it's important that we understand structural violence that communities experience because we target them in our research all the time, and not to have an understanding or idea of what they actually experience can be problematic. And again, all of my theoretical understanding changed so much when I went into people's homes. I was like, oh, I'm this amazing PhD researcher, and then I'm like, wait, this is poverty, this is real poverty, and it's very uncomfortable. It felt uncomfortable for me, so it made me reflect again on my outsider status and my positionality, and maybe how who I am might have influenced some earlier interviews. So until I got into that position, I wasn't even aware of my biases as it relates being in a home where a person might get evicted. So definitely eye-opening. So I'm gonna end there because I know. Yeah. And this was in March.
We have around 15-20 minutes before
Okay.
lunch, right?
Yeah.
45, I think we said. So how do we want to proceed in terms of reflecting on this with respect to, our own projects? There was one interesting.
I just wanted
Yeah,
to say
please.
this was absolutely amazing.
Thank
Yeah.
you.
And I think, just as someone who's on faculty here, just to see the work that you're doing is really.
Thank you. I learned, honestly, all of this, the conceptualization of this, I could have not done that without being in the Institute. I'm not just saying that because y'all are here, but it's true. I didn't know, that there was even a literature or evidence, a body that kind of talked about some of these things. Other people, maybe if you do ethnography work, you might know a little bit about it from anthropology, but in the ethics space, I wasn't familiar with any of this. So it really helped me to just resolve some things that I was feeling as a researcher. So this is a great place to be. I wouldn't come back, trust me. I've been in a lot of fellowship programs, and sometimes I feel like it's just
You wouldn't come back
if it weren't, yeah. No, I wasn't. No, I'm sorry. If it were not, yeah.
Wait, but you did
Wait, no. I've been in a lot of fellowship programs, and sometimes I feel like they're just lines on CVs as a junior faculty. There's just a lot of programs that we can apply to, and this has really like enriched my work in a way that I can say other programs have not. So yes, I would not say this. I would not be here if it were.
Double negative.
And I'll end. Yeah, I know. Sorry for the double
She was
negative.
coerced to say this.
Faith, your work has also enriched the research ethics community
Thank you.
over from your presentations nationally.
Thank you.